Good evening, everyone. Now, today's session is a 4 days of clinical module, oncology module. So, let me introduce our speaker. It is my privilege to introduce our distinguished speaker, Dr. Nazar Ali, PharmD, a highly skilled oncology clinical pharmacist at Adaya Cancer Institute, Chennai, where he has been serving since January 2024. Dr. Nazar Ali has extensive expertise in medical and pediatric oncology, specializing in areas such as chemotherapy dosage appropriateness, admixtures, adverse drug reactions reporting, and pre and post chemotherapy patient counseling. In addition, he plays a pivotal role in coordinating clinical trials, including randomization and administration of study drug. Dr. Azhar Ali completed his Doctor of Pharmacy at Vinayaka Missions Research Foundation, Salem, Tamil Nadu, in September 2023, where he was honored with the first rank gold medal. He also received the Merit Cum Means Scholarship for the Ministry of Minority Affairs for his outstanding academic achievements. Please join me in welcoming Dr. Nazar Ali, who will guide us through key concepts such as dose calculations, admixtures, and the emerging trends in oncology. We welcome you, sir.
Thank you, Ms. Tarini, for your brief introduction. Am I audible? Please, anyone confirm me.
Yes, sir.
Yeah, thank you. Thanks to the team Medodrix and Mr. John Felix for this wonderful organization regarding this basic module about the oncology. In recent trends, oncology is a growing concern regarding the type of the treatment advances. You can take it in terms of research. It is keep on updated. So it is really a good initiative, and thanks for making me a part of this. So let's get into the session. Let me share my slides. So this session has been, carried out for 4 modules. So during which we'll be discussing about various basic fundamentals, because it is very important to have a foundational knowledge and understanding about the concept before getting into the advances. Okay. So in today's session, I will be dealing with basic introduction to cancer. What are all the genetic scenarios happening, and what are all the various treatment modalities that can be uh, followed for the treatment of cancer. Okay, so in this we will be discussing about what is cancer and what is a neoplasm, and also we will be discussing about the characteristics of benign and malignant tumor, and cell cycle and its various regulators and checkpoints, and basic principles of carcinogenesis, and various serum tumor markers, cancer grading and staging, and at last we'll give a brief introduction about the treatment modalities. So let me start up. So generally, for defining the cancer, the people used to say it is an uncontrolled proliferation of abnormal cells, isn't it? So of course, it is an abnormal because a normal cell cannot undergo uncontrolled proliferation. Usually, all the cells in our body is undergoing cell division, but that cell division is happening in a controlled and regulated manner. But when this cell division is occurring uncontrolled manner, that's why we are calling the cell as an abnormal. But from where this abnormality comes, it is very important. Why these cells are being called abnormal? So here the second point, I have given one flow chart. Don't get confused with an arrow mark. I will explain you. So why we are calling the cell as an abnormal? Because these cells allowing the tumor promotion and progression. Okay, that is a tumor growth and the spread. Why these cells are allowing the tumor growth and spread? Because its re-regulatory systems are disrupted. We have certain regulatory systems that will regulate the cell division. So we have some proto-oncogenes, tumor suppressor genes, apoptosis regulators, which we'll be discussing later. So these are all the regulatory systems. So these regulatory systems are disrupted. How these regulatory systems are disrupted? Because of an acquisition of genetic error. How these genetic errors happening? Because of the damage to DNA. How the DNA is getting damaged? Because of an exposure to carcinogens. Those carcinogens can be a chemical, or it can be a virus, or it can be some of the radiations. Now, look up this flowchart in an opposite direction. Various carcinogens like chemicals or oncogenic viruses or radiations that causes damage to DNA, that results in a genetic error. It can be a point mutation, it can be in chromosomal amplification or translocation or overexpression, various mechanisms, but mutation is happening. So due to this mutation, the regulatory systems that regulates the cell division is disrupted. So as a result, what is happening? The cell is excessively, continuously, uncontrollably dividing, which allows the cells to form a tumor. That is a
Sir,
sorry.
sorry to interrupt you. I think the slides are not changed, have not been changed.
Actually, what you are seeing, can you please tell me?
It's in the first introduction slide.
First, it's not
Yes, sir.
changed
No, it hasn't been changed.
now.
No, not yet, sir.
हाँ अभी नहीं है अरे बाय now can you feel the change?
Yes, sir. It's an overview slide.
Okay, done. So now, okay. So, okay, let me restart. So, so here we have a second point there. The abnormal cell is allowing the tumor promotion and progression. Okay, why the cancer cells are being called abnormal? That explanation I'm giving. So these cancer cells are allowing the tumor promotion and progression. How it is allowing the tumor promotion? Because the key regulatory systems that regulates the cell cycle is disrupted. How they are disrupted? Because of the gradual acquisition of genetic error. How these genetic errors are happening? Because of the damage to DNA. How the DNA is getting damaged? Because of exposure to various carcinogens. Those carcinogens can be a chemicals, or it can be an oncogenic viruses, or it can be some radiations. Okay. Now just look up in the opposite direction. So these carcinogens causes damage to DNA, which results in a mutation in the genes. Each DNA having various sequence of genes. Each genes has two alleles. That all we know. So this mutation disrupt the normal key regulatory mechanisms. So as these regulatory mechanisms are disrupted, cell cycle is becoming unregulated and uncontrolled. So as a result, it allows for tumor promotion and progression. So those chemicals, what are all those chemicals? Especially arsenic, we have alcohol, nickels, chromium, vinyl chloride. So all these chemicals. Viruses, especially we have Epstein-Barr virus, which is having the potential to cause a carcinoma. And radiation, we have ionizing and non-ionizing radiation. Ionizing radiation due to the radiation therapy or due to nuclear reactor accidents, and various non-ionizing radiation, especially UV, ultra spectrum, ultraviolet, especially the major source is the sunlight. So usually it causes skin cancer like melanoma, basal cell carcinoma, squamous cell carcinoma of the skin. Now I'm coming what is cancer. You know, cancer can occur at any body tissue and at any stage. But the main developmental principle is an genetic error. That genetic error is happening because of an exposure to carcinogens. Okay. Now one more thing which we have to understand, the cells, for example, you can take one tumor. All the cells present in that tumor are monoclonal. That is, they are derived from a single mother cell. That single mother cell will keep on dividing. One cell will become two, two will become four, like that. It will keep on divide, and as a result, there is a new mass of tissue that is called neoplasm or tumor. Okay, so as I already said, the new tissue growth produced as a result of unregulated cell cycle or cell division is called neoplasm, or it can also be called as a tumor. So when it's happening, usually all the cells will have a growth factor receptor. So when a cell needs to divide, a growth factor will come and bind to the receptor, which will then signal to the nucleus that the cell needs to divide. So then the cell will undergo mitosis, as a result of which two daughter cells will be formed. But in cancer, what will happen? The cell cycle may keep on continuing. The cell may undergo mitosis even after the cessation of stimuli. What is the stimuli here? It is a growth factor. So usually I will be explaining the cell cycle in the later slides, but I'm just giving you an introduction here. Okay. So we have seen what is a tumor, how the tumor is formed because of uncontrolled proliferation, how uncontrolled proliferation occurring, what are all the mutations happening, how mutations happening, we have seen. Now I'm coming to the types of tumor. Okay. So we have two types, benign and malignant. The main characteristic difference between the benign and malignant is two. One is benign will be well encapsulated and well circumscribed. You can appreciate from the images here. Whereas the malignant tumors are irregular in shape and they are non-capsulated. Okay, one more thing, the benign tumor will remain localized. It will not invade the nearby tissue and it will not undergo distant metastasis. Whereas the malignant tumor will undergo distant metastasis and it may invade the nearby tissue, which you can easily appreciate from the diagrammatic figure representations here. So next, coming to the nomenclature, you all know that all the benign tumors ends with the suffix oma, all the malignant tumors may end with carcinoma, sarcoma, like that. But there are five exceptions. Those five cancers that ends with oma are malignant, they are not benign. So those are melanoma, seminoma, hepatoma, mesothelioma, lymphoma. So these five are the exceptions that ends with oma, but they are malignant. All other tumor that ends with the suffix oma are benign tumors. Then further categorization, we all will be knowing up to the level sarcoma, carcinoma, lymphoma, leukemia. We will stop with these four. But other than this, we have multiple myeloma, we have germ cell tumors, we have spinal cord tumors, we have various blastomas, So what is sarcoma? Usually, most common cancer we see is osteosarcoma, living sarcoma, like that. So it which arises from the bones or the connective tissue. So carcinoma is an origin from the epithelial cells. Example, lungs, liver, pancreas, everything. The leukemia are the cancers that originates from the bone marrow, and lymphoma is a cancer that begins in the TRB lymphocytes. Multiple myeloma is in a plasma cell. Melanoma, skin cells, brain and spinal cord tumors, different cells of nervous system, especially glioma, which is usually most common in children. And also we have germ cell tumor, we have neuroendocrine tumors, and we have blastoma. These blastoma is also very common in children. Various variants are there. Neuroblastoma, medulloblastoma, retinoblastoma, like that. So next, I'm coming to discuss about the characteristics of tumor. So as of now, we have seen what is tumor, how the tumor is occurring. Tumors and neoplasm both are same term. Neoplasm means new growth. New growth produced as a result of uncontrolled proliferation. That's it. Okay. So how characteristics we can discuss at the level of rate of growth, clinical features, gross features, microscopic features, and the spread of tumors. So first, rate of growth for the malignant cell. Malignant cell will grow at an increased rate. The doubling time, there is something called doubling time. The time taken for the cell to divide, that is the time taken for a two daughter cells to get formed. So that doubling time will be considerably low for malignant cell when comparing to the benign tumor cells. Okay, and also increased mitotic rate. First, increased mitotic rate, that is the increased growth rate. Second one, it is slow growing, but the malignant tumors are rapidly growing and it will remain localized, but the malignant tumors can invade locally into deeper tissues and to the distant organs. Okay. Next, gross features. Gross features, benign tumors usually will be a spherical or ovoid in shape. That is, it will be uniform. So you might have appreciated from the previous images now that benign tumors will remain well circumscribed, well encapsulated, so it will be a spherical or ovoid in shape. That is, it will be regular. But the malignant tumors will be irregular in shape. It will be poorly circumscribed and the surrounding tissues will be invaded. But whereas in benign tumors, the surrounding tissue only will get compressed. It will not be invaded by the tumor cells. Okay. So the next one is a microscopic features. So usually when a patient is diagnosed to have a cancer, so what is the next step? How they will get diagnosed? So that is removal. In biopsy sample or the tumor will be surgically removed. Okay. So after removing the tumor, what they will do? It will be sent to the pathology lab. So there the histopathologist will make a slide out of it. He will make a slide out of it using the endoscopic study. So this endoscopic study is important to characterize whether the tumor is a benign or it is a malignant. Okay. So what is the main thing they will see on the slide is the lack of differentiation. Okay, lack of differentiation in a sense, the presence of anaplasia. What is differentiation? Nothing but the extent on which the tumor cell resembles with that of the normal cell. How about the functional resemblance? How about the morphological resemblance? Okay, so that they will compare with that of the normal corresponding cells. So that is called differentiation. But in place of anaplasia, there will be a lack of differentiation. That is, the tumor cells will be undifferentiated. It will have no resemblance, both morphological resemblance and functional resemblance with the corresponding cell. So you can see those things will be showing on that slide, and then they will decide whether it is a benign tumor or it is a malignant tumor. Okay, so hallmark of malignant transformation is a anaplasia. Anaplasia means lack of differentiation. What is differentiation? Differentiation is extent of functional and morphological resemblance of a tumor cell with the normal cells. Okay. So what are the features of anaplasia? There are 10 features of anaplasia. So the first thing is the loss of cell malignant. Am I audible?
Yes, sir.
So after getting their sample, the histopathologist will make a slide out of it. So he will be observing for the features of anaplasia. First thing is the loss of basal polarity. So in normal cells, the nucleus will be towards the basement membrane. Whereas in a malignant cell, the nucleus will be irregularly arranged. It will not be towards the basement membrane, which is the first characteristic feature. Second one is the pleomorphism. Pleomorphism is a variability in size and shape of the cell. You can appreciate from the image. So in a normal cell, all the cells are regular in size and shape. But whereas in a cancer cell, the cells are irregular in size and shape. Third one is a nucleocytoplasmic ratio. So look at the normal cell. There is an uniform sized nucleus inside the cytoplasm. So if you take the N by C ratio, it will be low. It will be is like 1 is to 4. But in case of a malignant, that is a cancer cell, the N is to C ratio will be high because of large proportion is shared by the nucleus. The fourth feature is anisonucleosis. So variation in size and shape of the nuclei. You can clearly appreciate from the image. In a normal cell, the nucleus are normal in size and shape, whereas in a cancer, the nucleus is an irregular in size and shape. Fifth one is an hyperchromatism. So nucleus, because of high nuclear material, it is taking more stain. So it is very darker in color when comparing with that of the normal cell. Sixth one is a prominent nucleoli. In normal cell, if you are conducting a microscopic study in a normal cell, you cannot appreciate a prominent nucleoli. But in case of a cancer cell, we can appreciate a prominent nucleoli. Next is an mitotic figures. You can see the figure here inside which we can clearly see the mitosis. But in case of a cancer cell, we cannot see. Sorry, in case of a normal cell, we cannot see a normal mitotic figures. Eighth characteristics is a giant cell. Giant cell is a multinucleated cell. So you can see multiple nucleus present within a single cell. But in normal cell, we cannot observe such things. Then we have normal cytoplasm. Mucin increase the cytoplasm. And the 10th one is an diploid chromosomes. We have 23 complete pairs of chromosomes. But in cancer cell, we may observe aneuploidy. So these 10 features, if they observe out of it, if any 8 features are present or if any 7 features present, they may predict the tumor is a malignant. It is not a benign tumor. Okay. So now I have confirmed that the patient is having a malignant tumor, that is he or she is having a cancer. So next I have to see whether it is already metastasis or not. Only the malignant tumor can undergo metastasis. Benign tumor will remain localized. Only the malignant tumor may undergo local invasion and metastasis to the distant, that is distant different organs. So how they will undergo metastasis? There is a primary tumor formation. So after which it may locally invade the nearby tissue, and then it will send the new tumor cells into the blood vessels. Blood vessel may survive, tumor cells will survive in the circulation, and it may get arrested at certain organ sites, distant organs, and again transport of the tumor cells out of the blood vessels, micrometastasis, colonization, then it may form the detectable metastasis. So usually, when a patient comes, he or she is confirmed to have a cancer. Then they will check for the presence of metastasis. Depending on which only they will decide whether we have to conduct a surgery, or whether we have to start a chemotherapy or radiotherapy. So for that, they will send the patient for PET-CT. Okay, in initial days only PET scan will be done. Now we are conducting PET-CT, so in which the patient will be observed with some radio opaque glucose. They will be injected with the radio opaque glucose called FDG. So this glucose will be administered to the patient. So what this glucose, that cells with higher metabolic activity will take up this glucose. So when you observe with PET-CT, all these cells will glow up. So by that they can confirm whether if it is metastatized or not. So if the cancer is already metastatized, there is no scope of surgery. So they will give only the palliative chemotherapy. So if it is a non-metastatic, or if it has undergone only micrometastasis, at that time they may consider for uh, surgery followed by chemotherapy. Okay, so those modes of chemotherapy, modes of treatment we will be discussing later. Now coming to the cell cycle. So I don't know whether the slide is completely visible to you or not. So as of now, we have seen what is a tumor, how it is happening, what are all the types of tumor, how the cancer is being named, its nomenclature, and how about the characteristics of the benign and malignant tumor, and how about the features of anaplasia. Now, before get why I'm adding cell cycle after all this, because here you will know where the change is happening, how the where the change is happening, how the normal cell division is becoming unregulated. Okay, so you all know that the cell cycle consists of four phases: G1 phase, S phase, G2 followed by mitosis. So what will happen in G1 phase? Only the RNA and protein will get synthesized. No DNA synthesis. DNA synthesis will happen only in S phase. In G1 phase, RNA synthesis and protein synthesis. So followed by G1 checkpoint will be there. Okay, that checkpoint, it will check whether the sufficient substrates are available for DNA synthesis, whether sufficient proteins are available. So it will be checking the cell. Then only it will send the cell from T1 to S phase. And S phase, what will happen? There will be a DNA synthesis. Okay. And some of the RNA and proteins will also get synthesized. Followed by G2 phase. G2 phase, no DNA synthesis will happen. Okay. Only the RNA and protein synthesis. After that, we have G2 checkpoint. So which will check for the DNA, any errors or there. If any errors is there, it will call out the DNA repairing genes, which will be repaired, followed by mitosis. Then the cell will be formed into two daughter cells. What will happen after mitosis? There are three options. The cell may re-enter the G1 phase. If further cell division is required, okay, further cell division required, the cell may re-enter the G1 phase, or else it can make a reversible exit to resting phase, G0. So usually the cell will remain in the resting phase only. On the resting phase, if the growth is needed, the growth factor will come and bind to the growth factor receptor, then the cell will undergo cell cycle. Okay, so it can make a reversible exit to resting phase. The third option, it can make an irreversible exit from the cell cycle, and it can get differentiated into some whatever the organ. Okay, so this is what is happening in the cell division, which consists of four phases. No need to get deeper into this. We should have some idea what is happening in the cell cycle. Okay, so this cell cycle, so now we have seen what is happening in cell cycle. So these cell cycles, as I said, we have three checkpoints. One is G1, one is G2, that is at the end of the G1 phase. Another one is at the end of G2 phase, another one during mitosis. So at the end of G1 phase, it will check for any DNA damage, and it will ensure whether the substrates are available which required for the DNA replication. And if any if necessary, okay, if anything is insufficient, the cell cycle will be stopped here. Okay, which is coordinated by these checkpoints. These checkpoints are regulated by some cyclins and cyclin dependent kinases. which we will discuss later. So G2 endpoint at the end of G2 phase, here the cell will be examined for the DNA replication. Okay, so a single stranded DNA is divided but converted into two double stranded DNA. So there they will check for any errors. If any error, they will call out the DNA repairing genes. These genes will repair the rectify whatever the errors happen, it will repair so that the cell may progress to the mitosis phase. But if the cell cannot repair, it will initiate the programmed cell death, okay, which will prevent the damaged gene from being passed on. So next checkpoint is happening during M phase. So it will determine whether the chromosomes are about to be correctly distributed or not. Now coming to the cyclins and cyclin dependent kinase. Now this entire cell cycle is internally regulated by the proteins called cyclins. Okay. So cyclins are proteins, but the cyclin activity is influenced by a protein such as P53 and retinoblastoma. So this P53 and retinoblastoma are tumor suppressor gene. Okay, so this tumor suppressor gene can stop the cell cycle. If any error, if any issue happen, this tumor suppressor gene can halt the cell cycle. Okay, so in cancer cell, what is happening? The functions of these checkpoints are limited. So this leads to uncontrolled cycling even in the presence of DNA damage. Usually, if any DNA damage, these checkpoints will encounter it. Okay, it will not allow the cell to pass on to the next phase. But in cancer cells, the function of these checkpoints are usually limited. Why it is limited? Because its activity is influenced by P53 and retinoblastoma, which are tumor suppressor gene. These tumor suppressor genes are getting mutated. That's why its activity is limited in cancer cells. Okay. So now let us come to the basic principles of carcinogenesis. Now only we are coming to the proto-oncogene genes, tumor suppressor genes and all. So we have mainly two group of genes that control the cell division. One is proto-oncogene, another one is a tumor suppressor gene. Okay. So this cancer formation is initiated as we have discussed in the first slide. I might have showed you one flow chart. Okay. So the cancer formation is initiated by the DNA damage. Okay. But that some DNA repair mechanisms may overcome that damage. But, but there is an increased risk of cancer in the presence of mutations. So what happened? DNA mutations eventually disrupt the regulatory system. So what are those regulatory system? We have three regulatory system. One is proto-oncogenes, another one is a tumor suppressor gene, followed by the apoptosis regulator. These three things. So proto-oncogenes are actually will naturally present in the cell. Okay, so it can be at the level of growth factor or it can be a growth factor receptor, signal transducers at various level it will present. But if these proto-oncogenes are get mutated, it will become oncogene. So actually normally this proto-oncogene will not promote the cell division. If any errors happen, it will not allow the cell cycle to move on to the next phase. But if it is getting mutated, it will promote the uncontrolled cell division. Likewise, tumor suppressor gene is also opposite to that of the proto-oncogene. It will stop the cell cycle. It will not allow the tumor to get formed. But if getting mutated, it will be deactivated. So the mutation we have in point mutation we have two. One will be a loss of function. One will be a gain of function. Okay. In proto-oncogene there is a gain of function mutation. Okay. So usually proto-oncogenes will promote cell division, but if it is getting mutated, it will be hyperactive. So it will be keep on promoting excessive cell division. But tumor suppressor gene normally it will not promote cell division. So if it is deactivated, it will loss of control mechanism. Tumor suppressor gene is having a control over the cell cycle. So since it is mutated, there is a loss of function mutation. So it is not functioning properly. So it leads to a tumor formation. Okay. So now what are oncogenes? So proto-oncogenes are essential for cell growth and differentiation. So if these proto-oncogenes are mutated, it forms an oncogene. This oncogenes leads to unregulated cellular growth. So what are oncogenes? So we have various growth factors like plasma, platelet derived growth factor, we have growth factor receptors, and we have at this level of signal transducers. And one more thing is a cell cycle regulator mediated progression. Okay, so I will give you one example about the oncogene, one example about the tumor suppressor gene. So one classic example for oncogene is a RAS gene. Okay, so RAS is associated with the growth factor receptor. Usually, as I said, on the surface of a cell, we have a growth factor receptor. Whenever a cell needs to divide, a growth factor will come and bind to the receptor, as a result of which will send signal to the nucleus that the cell needs to divide. So after that, the cell will undergo mitosis. Okay, so now the RAS is a gene that will be attaching with the growth factor receptor in an inactive state. It will be bound with the GDP. So if any substrate comes and bind to the receptor, this GDP will be converting to GTP due to the phosphorylation, so which will activate the RAS gene. So if the RAS gene is activated, it will send the growth signal to the nucleus. Okay, in a normal cell, we have a growth factor receptor. This growth factor receptor is bounded with the RAS gene. Okay, so RAS is inactive state when it is GDP bound. But whenever a substrate, whenever a growth factor comes and binds to the growth factor receptor, that phosphorylation occurs so that the GDP will be replaced with the GTP, as a result of which the RAS will be activated. So what this activated RAS does, it sends growth signal to the nucleus. So now, after sending the growth signal, the RAS needs to be inactivated. So there is an enzyme called GTPase. Okay, so this is an GTPase enzyme which will inactivate the RAS by cleaving the GTP to GDP. Usually, RAS will be inactive, bounded with the GDP. Only GDP converted to GTP becoming active. Okay, so after done whatever the duty to be done, the RAS has to come back to the inactive state. So it can be done by cleaving the GTP to GDP. This is usually done by GTPase. Now, if the RAS is mutated, it inhibits the activity of GTPase. So what will happen? The RAS will not be able to come back to the inactive state. So there will be a prolongs the active state of RAS gene, which will result in increased growth signal to the nucleus. So normally RAS will send growth signal to nucleus, but in case of mutation, there is a prolonged active state of RAS gene. So which will keep on sending the growth signal to the nucleus, as a result of which the cell will keep on divide, which ultimately results in the formation of a new tissue growth. Okay, then coming to tumor suppressor genes. The tumor suppressor genes, we have two classic examples. One is P53, another one is a retinoblastoma. So P53 regulates the progression of cell cycles from G1 to S phase. That's why I have already told you the functions of the cyclins. No, they are important to the tumor suppressor gene. That is P53 and retinoblastoma. So, if any DNA damage occur, this P53 will slow down the cell cycle, and which will call the DNA repairing enzyme. So, it will ask the repairing enzyme to repair the damage occur. But if that repair is not possible, what the tumor suppressor gene will do? It will induce apoptosis. So, what it will do? It will upregulates the BAF, which disrupt BCL2. BCL2 is a molecule that stabilizes the mitochondrial membrane. So if this BCL2 is disrupted, okay, the cytochrome C, which is present inside the mitochondria, will be leaked out into the cytoplasm, which will activate the caspases, as a result of which programmed cell death will happen. Now here there is a important mechanism. For a tumor suppressor gene to get mutated, we need two hit. Okay, both the copies, both the alleles of the P53 gene must be knocked out. Okay, so for that we need two mutations. Okay, so if the two mutations are environmental, due to the environmental factors, that is there is a term called sporadic or somatic mutation. In that, both the two hit, both the two knockout will happen during the lifetime. But in case of germline mutation, first hit will be hereditary from the parents. Okay. Second hit is somatic. That is during the lifetime. Okay, for the tumor suppressor gene to get mutated, we need two mutation. That is, both the copies of both the alleles should be mutated. In that, if the first mutation is hereditary and the second one is somatic, it is a germline mutation. If the both the mutation is occurring during the lifetime, that is after the birth, during the lifetime due to then carcinogenic exposure, it is a somatic mutation. Okay, both are somatic. Okay, here one example we have retinoblastoma. So retinoblastoma regulates the progression from G1 to S phase, as I've already told you. So how this retinoblastoma is functioning? So in that RAS we have seen this RAS is bounded with the growth factor receptor. So whenever a growth factor comes and bind, RAS will become activated. So which will send a signal to the nucleus. But when the RAS is mutated, it will prolong the active state of the RAS, results in excessive growth signal to nucleus, as a result of which tumor forms. But in tumor suppressor gene, there is a retinoblastoma gene which holds a transcription factor called E2F. Okay, so which is necessary for the transition to the S phase from the G1 phase to S phase. So normally this E2F will be released when the retinoblastoma is phosphorylated by the cyclin and cyclin dependent kinase complex. But if the retinoblastoma is mutated, there will be a free E2F. So usually E2F will not be available freely. It is available only when the retinoblastoma is phosphorylated by cyclin and cyclin dependent kinase. Okay. But if in a mutated state, there will be a free E2F transcription factor available to allow the progression of the cell cycle from G1 to S phase, even in the presence of DNA damage. Okay. So that is how the mutation, it may cause a loss of function or it may cause a gain of function. Okay, so here also both the copies of the retinoblastoma gene must be knocked out for tumor formation. So I have told now sporadic mutation means both the hits are somatic, that is happening during the lifetime because of environmental triggers or because of an exposure to carcinogens. But in case of germline, first hit will be familial, it will be a hereditary from the parents, that is it will be present by birth. Second hit only somatic. Okay, so you can appreciate from this picture, which is Knudson's two hit hypothesis. So in the left image, there is an hereditary mutation. So if hereditary mutation, you can, if it is hereditary, all the cells, one allele of the retinoblastoma gene will be mutated, isn't it? So that if somatic mutation occurs, bilateral retinoblastoma will happen because already all the cells are, or yeah, single allele is getting mutated. So after somatic mutation, there are possibility for multiple tumors and bilateral tumors. But in case of sporadic, during the lifetime only, both the hits are happening. So both the hit will may happen at the same cell. So here the unilateral retinoblastoma will happen. But whereas in hereditary, there is a chances for bilateral retinoblastoma. The third regulatory system is an apoptosis regulator, so which we have already discussed, that BCL2. So BCL2 is a molecule that usually stabilizes the mitochondrial membrane, so which will block the release of cytochrome C. So if this molecule is disrupted, it will allow the cytochrome C to enter into the to leave the mitochondria and it will activate the apoptosis. Okay. Now, there are some serum tumor markers, which are the proteins released by the tumor into the bloodstream. For example, for the uh, we have CA125 for carcinoma ovary, so HER2 for breast cancer, ERPR receptors. Like that, there are some tumor markers, which are the proteins released by the tumors into the stream. We also have CA153 for breast cancer, CA19 for pancreas, prostate specific antigen for prostate cancer. So which can help in diagnosis, and also we can monitor the response to the treatment, and to monitor the recurrence also, it is very useful. Now coming to the grading. So grading usually done at the level of differentiation. We have already seen what is differentiation. It is an extent of functional and morphological resemblance of a tumor cell with that of a cancer cell. Now, if the cancer cell is well differentiated, it will be a low grade. If it is a poorly differentiated, it will be high grade. Okay, so in grade 1, the cancer cell will be well differentiated with slight abnormalities. Whereas in grade 2, cancer cells will be moderately differentiated from that of a normal cell, but more abnormality will be there. What is an abnormality? That is the features of anaplasia, which also we have already discussed. So third is a poorly differentiated, which is grade 3. The cell will be very, very abnormal. And grade 4, the cell will be completely undifferentiated and there will be immature cells. Okay. Now coming to the staging, the most common method is a TNM staging, depending on the tumor size, nodal involvement, and the presence of metastasis. Okay, so that is a TNM staging. Clinically, more useful. This is the system which most of the hospitals are utilizing. Now, by this, we have completed the basic foundations about the cancer. Okay, what is a cancer? It is an uncontrolled proliferation of abnormal cell. Why the cells are abnormal? Because that cell is promoting an tumor growth. Why it is promoting tumor growth? Because of regulatory system is disrupted. How the regulatory system disrupted? Because of DNA damage, which causes genetic error. So DNA damage, how it is happening? Because of exposure to carcinogens. So this entire thing we have explained. What about the types of tumor? What are all the characteristics? How about the hallmark of malignant transformation, especially the microscopic features? Now, coming to the treatment modalities. Now, a patient is coming to the hospital. So we have diagnosed that the patient is having a cancer. Okay, that we have either we have taken biopsy, or if the tumor is operable, we have removed it surgically and have conducted an histopathological study. Presence of malignant features are there. The histopathologist confirmed it as a malignant tumor. Now, next step, what we have to do is we have to check whether it is metastatic or not. For that, I have already told you by PET CT. Usually, they will be checking whether there is a malignant metastatic cells whether present in any other distant organs. So, if there is no metastasis, they will go for surgery. Okay, in that surgery also, if the tumor is more than 5 centimeter, initially they will be giving a neoadjuvant chemotherapy or radiation in order to shrink the tumor. We have to reduce the size of the tumor to make it easily operable. Okay, so the local treatment modality is a surgery and a radiation. When they will go for surgery, if the tumor is easily operable. So if the tumor is not resectable, they will be giving the radiotherapy or the neoadjuvant chemotherapy. What is neoadjuvant chemotherapy? We will be discussing later. Okay, so to shrink the tumor, after that they will conduct a surgery. Okay, then regarding the systemic therapy, we have chemotherapy, immunotherapy, targeted therapy, and usage of various monoclonal antibodies and radioactive materials like iodine 131 will be used for thyroid carcinoma, like that. Okay, so first let us discuss about the surgery. Surgery can be curative or preventive. If the tumor is not metastatized, okay, it remains localized means it can be a curative surgery. So we can completely remove the tumor, but if it is already metastatic, there is no scope of performing surgery. We can't perform surgery at multiple sites. Okay, wow. Then it can be a preventive. For example, there is a familial history of breast cancer. That female can go to test whether there is a BRCA mutation or whether there is a ERPR, like that. They can go, they can check, they can examine themselves. And if found positive, prophylactically, they can perform mastectomy. Okay, so that kind of preventive surgery can also be done. But usually, surgery is followed by a chemotherapy under or radiotherapy, depending on the site. Okay, so, as I have already said, the most important determinant of a surgical therapy is an absence of metastasis and local infiltration. So, only if there is no metastasis, that oncologist will prefer for surgery. If it is already metastasis, some rare cases they may prefer surgery, but it is of no use. Okay, va? And also surgery may be used for palliation in some patients for whom the cure is not possible. Suppose the patient is very suffering, very malnourished, patient not able to tolerate. So in that case, they may perform surgery. Okay, and for the palliative purpose, we cannot make a cure. Only for the palliative purpose they may conduct, but very rare. Okay, so mostly they will prefer curative and preventive surgery only. If it is metastasis, surgery is the last option. So curative surgery, which simply involves the removal of the cancerous tumor, but in case of preventive surgery, is used to keep the cancer from occurring. So I have already seen if a female is found to have a BRCA mutation, he or she can perform my bilateral mastectomy. Recently, I have also seen one patient who has done preventive surgery. She has done bilateral mastectomy because she is having a familial history, and she examined herself. She is also having a BRCA mutation, breast cancer gene, BRCA gene mutation. So she did a preventive surgery. She has removed both the breast, bilateral mastectomy. So next about the radiation. So radiation is also a local treatment modality. So it's an administration of ionizing radiation in the form of X-rays or gamma rays. So we have to address one thing. This ionizing radiation itself is a carcinogen. Okay. So at some circumstances, it may also induce a mutation, which ultimately results in a uncontrolled cell growth. So method of radiation therapy, we have two methods: external beam, internal beam. We no need to get deep into the radiation therapy, but in order to discuss about the treatment modalities, I'm telling you all this. But the radiation therapy, they have a lot of toxicities. Usually, the patient, usually for the head and neck cancer, oropharynx, throat cancer, like the thyroid, for those cancers, they used to prefer radiotherapy. So these patients know mostly they will be having skin reactions and oropharyngeal mucositis, and also there will be an ulceration throughout the gastrointestinal mucosa. The patient will not be able to take the fluids or any oral intake, so that there will be a raised tube intubation for most of the patients who is taking radiotherapy. Okay. So next, coming to the systemic therapy. In systemic therapy, we have various options. One is a chemotherapy. Yeah, and under the chemotherapy, we have cytotoxic drugs, and we may give some hormonal therapy. We may give some immunotherapy. We may give targeted therapy. These things will be discussing in the next session about each and every hormone therapy, immunotherapy, everything. We will be giving the basic introduction about various systemic treatment modalities. Okay. So we have already seen boards of chemotherapy. So adjuvant, neoadjuvant, these two are the main thing which we need to remember. So neoadjuvant means treatment will be given before the surgery to shrink the tumor. Okay, to make the tumor easily resectable. Okay, so for that they will be giving neoadjuvant therapy. Then followed by surgery, they will give adjuvant therapy. So surgery, before surgery it is neoadjuvant. After surgery it is adjuvant. After the surgery, to microscope residual disease, to mop up the microscopic residual, they will be giving adjuvant therapy. So those things, one of the protocols, everything we will discuss in the next module. So in this module, we have discussed the basic foundations about the cancer and basics, very basics about the treatment modality. So if you have any doubt, you may ask your questions. We'll try to rectify, try to resolve. Am I audible?
Yes, sir, you're audible. I request all participants to ask your doubts or questions to the sir. You can either post it in your comment also.
Am I audible? Hello.
Yes, sir, you're audible. Shall we continue?
Yeah. What about the questions?
Uh, we have we have few questions posted in the chat box, sir. Uh, we have a question from Hariharan. What are the new tests to determine gene changes?
So new techniques, usually they may go for single gene or panel testing. If it is not providing diagnosis, or when the suspected condition or genetic cause is unclear, they may go for whole genome sequencing, like whole exome sequencing, like that. So Usually they will be performing single gene sequence, single gene or panel testing. Usually that is what happening. But the whole genome sequencing is typically used when that single gene panel testing is not providing that much information about the diagnosis or the suspected conditions.
Thank you, sir. We have another question. How does the knowledge of risk factors help in early cancer detection?
How does the knowledge of risk factor help in early colon cancer? Okay. Risk factor we cannot predict. How to say? We have marriages. So for example, in breast cancer, uh, people who tend to have a very less menstrual age, yeah, late, early menopause. These patients tends to have more chances of having the breast cancer. So having this knowledge will help in early cancer detection. We used to create awareness among the people. So if you have any familial history, or if you have a tobacco use, if you have alcohol consumption chronically, to come and examine yourself. So like that. So aspect of the person's age, their family history, their lifestyle, their environments, they can increase the risk of developing the cancer.
Okay, sir. The another question is about immunotherapy and in which cancer patient mostly used. They are
Yeah,
asking to
regarding the
explain about it.
immunotherapy, we will be discussing regarding the immunotherapy and targeted therapy in the next module. That is the next session tomorrow.
Yes,
I
sir.
think we will get an answer for this tomorrow.
Sure, sir. We have another question. What will be the role of clinical pharmacist in the whole criteria, or what's the role of research scholar to develop such drugs to alleviate the condition in a cancer patient?
Role of a clinical pharmacist, we can mainly deal with the dose adjustments, dose calculations, providing, conducting a drug interaction study, and there will be usage of antimicrobials for the cancer patients because when they are receiving the chemotherapy, their neutrophils counts and all will be considerably low. Okay, so these patients are more prone to infections. So we can assist that the physicians in the selection of proper antibiotics. So we have various scopes to show our skills, and a research scholar to develop drugs to alleviate. So, yeah, we may found some new advances like combinations. So usually for any drug, in order to overcome the toxicity, they will be giving some adjunct therapy. So we may think of the combination. For example, there is a drug called cyclophosphamide. So for that, it is having the potential to cause hemorrhagic cystitis. So in order to prevent the occurrence of hemorrhagic cystitis, they will give another substance called mesna. So future we may think of combining the ifosfamide and mesna to combat the hemorrhagic cystitis being caused by the ifosfamide metabolites. So like that, we have a lot of scopes for the research also.
Okay, sir. Uh, a final question. Does MRI scan have paramount role in detecting and treating cancer?
MRI up to certain extent. So mostly we'll be going for PET CT.
Okay. Another question has been posted by Sai Lavanya. Is it okay to treat a single tumor with ionizing radiation even with the risk of inducing carcinogenicity to other tissues?
It depends. See, inducing carcinogenicity is not a common phenomenon for all the patients. It depends. It's about the dose. It's about the intensity of the radiation. So, if it is a single tumor, radiation is not a first choice. First, if it is a benign or if it is malignant, if it is easily operable, they will be surgically remove the tumor. After that, they may combine chemotherapy or radiotherapy to prevent the micrometastasis. Okay, so inducing the carcinogenicity is not a normal principle, but there is a risk. which depends on the patient individual characteristics and about the dose of the radiation, which is intensity of the beam which is being used.
Okay, sir. So,
Thank you.
okay, sir. Shall we wind up this session?
Yeah, thank you.
Okay, sir. So, thank you everyone for joining us today. We hope you found the session valuable and informative. Our second session will continue tomorrow at 7 p.m. We look forward to seeing you all then. Have a great evening. Thank you, sir.
Yeah, thank you.